Hi, I'm Chris Martey, a first contact physiotherapist with a special interest in rheumatology. I'm delighted to contribute to this knowledge hub for the National Axial Spondyloarthritis Society. First contact practitioners in primary care are experts in musculoskeletal medicine and therefore are very good at understanding what is atypical of this and therefore what presents perhaps as a non-musculoskeletal pathology such as an inflammatory rheumatic disease. Therefore, first contact practitioners are certainly vital in helping reduce the delay to diagnosis of conditions like spondyloarthritis. So, I'd like to share 5 top tips for recognising and managing the early referral through to rheumatology for people with axial spondyloarthritis. For all people with chronic back pain with an onset under 45, think spondyloarthritis. Make sure you recognise inflammatory back pain and the characteristics of this. I'd like to really state that people should thoroughly question early morning stiffness and the subjectivity around that. It's important to know the extraarticular manifestations associated with spondyloarthritis and also reach out and link with your local rheumatology services. For all people with chronic back pain younger than the age of 45, think axial spondyloarthritis. It's important to remember that this condition isn't as rare as you might think. Approximately 1 in 200 individuals in the UK are living with this condition. The classification criteria changed in 2009 to move away from just the radiographic X-ray changes synonymous with ankylosing spondyloarthritis or radiographic axial spondyloarthritis, but with the advent of MRI changes and sacroiliitis on MRI imaging, it now has a wider net of people who can be diagnosed with this condition. The next is inflammatory back pain recognition. I often think physiotherapists are brilliant at recognising what isn't mechanical back pain, but I want to remind people that it's not as simple as saying it gets better with movement or it's worse with rest, which we often do think. Sometimes a lot of the cases I'm picking up in primary care are synonymous with the night pain or the waking in the second half of the night and really questioning around that. I've had a case just last month where a patient presented with alternating buttock pain. That needs to raise our index of suspicion for an inflammatory condition. Next, it's important to really be aware of the extraarticular manifestations associated with spondyloarthritis, particularly the eyes with acute anterior uveitis, the skin with psoriasis, and inflammatory bowel disease, so ulcerative colitis and Crohn's disease. There are other extraarticular manifestations as well around dactylitis and enthesitis. These terms you need to be familiar with, and the NICE guidance is a useful aid memoir to look into this. It's also important to point out about blood tests and how they contribute to the clinical picture of somebody with axial spondyloarthritis. HLA-B27 is not diagnostic of axial spondyloarthritis, but of course a large proportion of people may be positive for this blood test. My next piece of advice would be to really question early morning stiffness of the joints or the spine. This in itself is subjective, but we know joint stiffness is linked to pro-inflammatory changes in the body. So really question not just the quantity, but also the quality of that stiffness, the patient's qualitative wording around this, because it really might lead you into understanding whether this sounds inflammatory. Lastly, make sure you email and link with your local rheumatology services. Find out what the local pathways are and what they would like or wouldn't like first contact practitioners to do. For instance, where I work, they're quite happy with us requesting for the HLA-B27 blood test in primary care. However, we need to make sure that we're comfortable understanding that this may be negative, but patients still may have the condition. Alternatively, they're not keen on us doing the MRI spinal protocol from primary care, and actually they would much rather us refer anyone we're suspicious of through to them to make that decision. So do connect with the teams, and this goes without saying, not just for spondyloarthritis but with all rheumatic conditions. Our job in primary care is to think inflammatory, think non-musculoskeletal, and if we are thinking that, think we want to refer early, screen where you can, ask the appropriate questions, make sure you try and figure out those SpA features, spondyloarthritis features, and get a prompt early referral to rheumatology. This way we can really help reduce the delay to diagnosis of this group of conditions.